the last talk on the tumor microenvironment, which has been touched upon many times, well, not many times, but several times during this workshop. This idea is going to be expanded upon in the last session. So the interplay between the tumor cells and multiple cells in the host, fibroblasts and immune cells and cells of the vasculature and bone marrow cells are now being recognized as extremely critical in the way the tumor cells behave. Dr. Munshi, who's a physician scientist, he's an assistant professor in the Division of Hematology Oncology. He both sees cancer patients and directs an active research lab, which is focusing on the importance of the tumor environment in pancreatic cancer and in oral cancer. He is going to give this last talk. I think that's it.
That's good enough.
It's good enough. Okay. So.
Thanks, Bonnet, for the introduction. I'm an oncologist. I primarily see patients at the VA hospital. So even though my lab works on pancreatic cancer and oral cancer, in clinic I see everything. In terms of I see leukemia patients, I see lung cancer patients. I don't see that many breast cancer patients simply because it's the VA hospital where we primarily have men over there. So I'm sure somebody in the course of this seminar or symposium covered each and every aspect of tumor progression. Normally, you have a primary tumor there that eventually it grows and it breaks through the basement membrane. So the basement membrane, once it breaches the basement membrane, you come and you say the tumor has become invasive. And so once it becomes invasive, it enters the bloodstream, gets to the bloodstream, and then it clogs. The question you had asked was, how does the cancer cell get to where it gets in the first place? So if you think about it, it usually ends up going to the lung or the liver or the bone. Often what happens, the cancer cell is quite big. It goes through small capillaries. It essentially gets stuck. Other times what happens is that you have platelets that bind to cancer cells, and because of that, there's interaction between platelets and endothelial cells that allows the cells to escape to get stuck at a particular spot and grow and into a primary site. So what you have here, at every place, you have something called the tumor microenvironment. So even though all this white area here, you can see you have got cancer cells invading to this white space. That white space technically is, if you think about its matrix, mostly type 1 collagen. And you also have, as Bennett mentioned, you have fibroblasts, endothelial cells, inflammatory cells, and you can see all of that. So here's a picture of a couple of tumors. So this is breast cancer, poorly differentiated breast cancer. And you can see you could stain breast cancer cells with brown membrane marker. And you can appreciate this is the cancer cells. And all around the tumor cells, you have this compartment. And you can appreciate that you have all these small nuclei there. Those are fibroblasts. And so this is breast cancer. And this is stomach cancer. So this is stomach cancer. And what you have done here is you have stained the tissue with a trichrome stain that allows you to appreciate type 1 collagen. So here's your type 1 collagen. And here are your fibroblasts. When most people work in the lab, so most of the time the focus is on cancer cells. And the reality of the matter is that when you do stuff in tissue culture plastic, I'll bring a couple slides later, is that a lot of it is in 2D tissue culture environment. Most of the time you're working in 3D. Most of this stuff this is a ball of tumor growing somewhere in somebody's stomach, or cancer cells growing in somebody's breast tissue. And so there's a difference between 2D microenvironment and 3D microenvironment. There's also a big difference between doing stuff on essentially very high rigid matrices versus normal soft tissue versus, so if you think about breast tissue is relatively soft, bone is relatively stiff, and then tissue culture plastic is extremely stiff. I think people are familiar with Valerie Weaver's work in terms of biomechanical forces and how that affects gene expression. So you can come back and say, okay, I see cells that look abnormal. I don't think they're cancer cells, so you can stain them. I'm not sure whether anybody covered about staining the last few days. So here you're looking at staining for mast cells in oral cancer tumors. So here, all of this is oral cancer cells, all of those things. And surrounding the oral tumor, you see all these little brown dots. So these are different kinds. These are mast cells, one of those white blood cells, monocytes that have differentiated into some of the some more specialized form. Here you're looking at the same thing. Here's another oral cancer, same oral cancer specimen stained with fibroblast marker called alpha smooth muscle actin, showing that these fibroblasts are in fact active. They have contractile function. So they are called myofibroblasts. There's a lot of crosstalk between cancer cells and stromal cells. So here's a picture of mouse epithelium showing the staining for HGF, or hepatocyte growth factor. For your purpose, it might as well be ABC. Here's the protein ABC, and you can appreciate that it's mostly expressed in the middle of this finger-like structure called villi. Surrounding, and if you look at the expression of its receptor, MET receptor, that is not expressed. It is expressed on the surface of this villus cell. So you can say there's a lot of crosstalk between the growth factor and the growth factor receptor. So again, I'm telling you how closely the tumor microenvironment interacts with the cancer cells and affects the behavior of these cells. Here's another picture showing the relationship between colon cancer cells that have gone to the liver. Here's your normal liver. Here's your stroma. And you can see there's a lot of crosstalk. Some of these inflammatory cells have come and have sometimes interesting to realize that you have this stroma in the primary site. When a cancer goes to some other spot, for example, the liver or to the lung, you come to appreciate that they sometimes bring along or tag along or create a microenvironment that essentially resembles the microenvironment that was present at the primary site. So there is that aspect to it. And I'll show you a little bit of what we do in the area of pancreatic cancer. So having shown you a few examples, you could appreciate there is a crosstalk at the level between cancer cells, endothelial cells, your cancer cells, inflammatory cells. Of course, inflammatory cells come in different flavors. You've got your lymphocytes, you have your monocytes, you have granulocytes, cells that Crispino and Licht work on, and you also have fibroblasts, you have adipocytes. You can imagine every cell type that you can imagine in the body interacts with cancer cells. And the interaction happens at the level of growth factors. The cancer cells can produce growth factors that can affect the behavior of all of these cells, can make proteases, cleave the underlying matrix, and because of cleaving the underlying matrix, affect the behavior of all of these cells. Similarly, the fibroblasts can put down growth factors, and you can read the literature and read the Weinberg's book and tell you stromal-derived factor, a whole bunch of proteins, depending on what you're studying. That can affect the behavior of cancer cells again. So there's this loop, complex loop that always plays out. And the question always comes is, who cares? Why should I study about something that goes on? I might as well study a single, a cell in a test tube somewhere. So if you look at it, you can ask that question, and you realize that you could do mouse experiments and say, okay, let me look at the behavior of mouse these are human memory epithelial cells and grow them in the mouse. And on average, whatever this experiment was done, is that about half the injections will form tumors around day 50. And it will take and by the time tumors get around day 70, about 300 and 350 millimeters cubic in size. If you provide them with some basement membrane, remember I showed you the very first picture, this basement membrane. So you could purify that basement membrane, call it Matrigel, and then you inject it together. You realize that almost 100% of the tumors take. And they grow faster, and they grow earlier. And if you inject breast cancer cells with fibroblasts, you can just look at that. You can appreciate that instead of growing at 50 days, you begin to see tumor growth around day 20, and they grow much more rapidly. So it already tells you that the biology, there's a lot of crosstalk that you can come to appreciate. And of course, people have studied the question, what happens if I take cancer-associated fibroblasts versus normal fibroblasts? What is the interaction between those two cells? You can ask those sort of questions too. What we work on, and that I'll come back to the question of the importance of the tumor microenvironment. So here's the survival curve of patients with pancreatic cancer. So on average, if somebody gets pancreatic cancer, most of them die within a year. Half of them die around in 6 months' time. This has been the result for the last 30 to 40 years. After 30 years of clinical work, they found that there's this drug here, EGFR inhibitor, improved the survival by about 2 weeks. And because of that improvement, FDA granted approval. So, and the question is the tumor microenvironment have anything to do with this poor outcome? You can say, are these cancer cells inherently resistant? You can take these cancer cells out, you can grow them in your tissue culture, and you can throw any chemotherapy you want. Most of the cells will die initially. It is something about the tumor microenvironment that limits the delivery or perhaps some other survival signals that dictates this poor outcome. Well, let's see, nobody's eating any cookies, I see. But anyway, if you ask the question, where is the pancreas? I mean, if I ask you, where is your brain, most people know where the brain is, and I hope. But where is your pancreas? If you ask, so here's, I call it the macroenvironment of the pancreas. So the pancreas lies just behind your stomach, right? And is very closely opposed to the spleen. So if you have a tumor growing somewhere here, it can invade into the spleen. If it grows somewhere around here, it can invade into the big blood vessels. And you can appreciate that for a surgeon to cure any particular patient, they need to give us negative margins. From my point as an oncologist, if a surgeon gives me some positive, if he leaves some cancer cells behind, he might as well not have done that surgery. So the question is, because of the location, it becomes quite challenging to detect this cancer early on. And also, the symptoms that most of these patients present with are very nonspecific initially. So this is what the pancreatic cancer looks like under the microscope. So if I were to ask you which of this, if you look at this picture here, which of this, where are the cancer cells and where is the stroma? So you can see on this particular field, this is a cancer cell, adenocarcinoma here, here, here. The majority of it is, in fact, the stroma. And you don't really appreciate that many blood vessels either. So if you deliver a drug somewhere here with a blood vessel, right? And so that drug has to go through all of this to get to here, and then, so the big issue comes of delivery also. All right, so let's see, how early, let me skip this slide. So going back to the theme of crosstalk, there was a paper that came out last year from the Tuverson's group showing that if they affected one particular crosstalk between the stromal cells and epithelial cells called the Hedgehog pathway. The Hedgehog pathway is the cancer cells make a particular protein called Hedgehog, binds to another receptor on the cell surface. That causes signaling to take place. That signaling results in more deposition of the matrix, proliferation of the stromal cells, and this signaling is also important for cancer stem cells. I think John Crispino can tell a little bit more about that. And also, so if you block this particular pathway, so it's been done in the mouse at least, if you block this particular pathway in realistic mouse models of pancreatic cancer, you can increase the delivery of the chemotherapy. That's the first thing. And you can improve the survival of mice by about 2 weeks. Still, so clinical trials underway to see whether this will hold true in the area of in humans. But a lot of times, if you think about it, lots of drugs get tested in patients. Most of the time, they work great. They work great on tissue culture plastic, because if they work in tissue culture plastic, that's what most of us what we do. You put it in mice, you do sub-Q injections, it works great. When it works great, you say, well, things I got a good result, then you take it to patients, and 99% of the time it fails. I could put my money down, it's going to fail. That's the nature of the reality. The next question becomes, are we using the wrong models to test our drugs? And it has come down to is that if you don't have the right microenvironment, if you don't model your cancer just right, especially in the solid tumors, you got to model them just right, because otherwise, often you find that your models were wrong in the first place. And if you use the right mouse models of cancer, either pancreatic cancer or lung cancer, you will show results that essentially mimic human disease. So they've done experiments using mouse models of lung cancer, and have found that if they model those and use some of the approved chemotherapy, the improvement is realistic about 2 weeks or a month at best. Same thing in pancreatic cancer. The reason why most of the drugs have failed in the past is one reason one could argue is that people are using the wrong model. And if you use this particular model, and you could show that even in this model that Tuverson put out, that gemcitabine has very little effect. EGFR plus gemcitabine has also very little effect. So this model is quite well replicate what we see in patients. At the end of the day, so here's another picture here. So here's your tumor. This, I think, is a colon cancer. Here's the tumor center. Eventually, cancer has to grow and invade in the surrounding tissue. And most of the surrounding tissue, of course, you have all these inflammatory cells. The major component of the surrounding tissue is type 1 collagen and extracellular matrix. All right, just like it. So it's a type 1 collagen. It's the most abundant collagen in the body. It means forms cross-linked meshworks of collagen fibrils, triple helical structure that really limits which proteases can cleave. So there are only a handful of enzymes that can really cleave type 1 collagen. means some of the matrix metalloproteases, even the class of 27 or so, only about 3 or 4 can actively do it in vivo. And there's a lot of cross-linking, and that can affect signaling. So here's another cartoon from showing integrin signaling. The point is that when cells encounter matrix, like type 1 collagen, you activate integrin. And this is one signaling pathway that can affect proliferation, cell survival. And you can also look at if you have changes in forces, and if you cross-link the matrix, if you have a lot more matrix, you'll have different signaling taking place. And you could also affect the forces that are sent from the cell surface to the nuclear membrane, from there to inside the nucleus. All of that can be modeled by cross-linking the collagen. So coming back to this question, when we do most of our tissue culture work, the reality of the matter is we work at this level. Normal breast tissue, the elastic modulus is around 500 to 1,000. Breast tumors around 5,000 or so. So, and what's been shown that if you alter the forces that the cancer cell or stem cells sense, for example, if you grow cells, if you grow your stem cells at high forces, you could get those cells to differentiate into bone. If you grow them at low forces, you can have them grow into neuronal brain tissue. And if you let them grow or in the middle, you can have them have expressions consistent with muscle. I think Milan Mrksic at U of C has also asked the question, is it the forces that dictate gene expression, or is it the cell shape? So he can ask the same question for the same amount of force, plating cells in a square form or versus in a cloverleaf form or into triangle, that affects gene expression. And of course, you can look back. I think a lot of this is Valerie Weaver's work in the, I think Burnett mentioned she's at Berkeley, UCSF, in the other PSOC funding. So what you see here is that when you cross-link the matrix, you have integrin signaling take place. So you've got focal adhesion kinases get activated. That affects Rho signaling, ROCK signaling, myosin. That results in forces being generated and cells moving or not moving in that sense. So you can appreciate some of the pictures here that the traction, the forces the cells are normally in breast tissue is around 500, breast cancer around 6,000 pascals. And then if you block the Rho signaling pathway, you can appreciate compared to this tumor here, the red being higher and I think blue being less. So you can see that by blocking this particular protein, you can affect the forces that the cells are experiencing. If you block this particular protein, ROCK, does the same thing. And if you use myosin, you can do the same thing. I think John can tell a little bit more about how this signaling pathway, ROCK, can affect differentiation of his AML M7 cell line. All right, so let's see. Okay, let's go back here. The big question is, how do you go about studying forces? You have to be careful. So for example, you say, let me put down more matrix. If I put down more matrix, are you controlling for forces? Are you controlling for more integrin clustering because it provided more substrates, right? So how would you go about studying forces in the lab, accounting for the fact that you don't want to adjust, you don't want to change any of your matrix deposition? So one could come back and say, let me put some biomechanical strain, do some stretching experiments. You could do that. Other thing you could do is that, like, I don't know whether many of the people in the lab in this group have run gels in the lab for Western. So if you take a 4% gel versus 15% gel, so 4% gel is quite soft, but 15% STS-PA gel is very stiff. So if you take those gels, you could coat them with matrix, and you could plate cells on it. And so you have a very low versus very high, and then ask the question, under those conditions, do you see changes in gene expression? Problem with that is that it's still a 2D. And as I mentioned, the 2D microenvironment doesn't quite reflect 3D biology to a very large extent. So what has been shown recently is that what Valerie Weaver's group also did is that she said, okay, I will change the forces the cancer cells sense by cross-linking the matrix. So what she did was that she took fibroblasts, expressed a protein called lysyl oxidase that can cross-link type 1 collagen and thereby increase the biomechanical force and stiffness of the matrix. And when she did that, she could show that under high stiff or under stiff conditions, you have more likely to have tumor progression than otherwise. Other thing she did was that she added ribose to the matrix to increase the stiffness of these 3D collagen gels. And by using these models, you could either model in 2D using SDS page gels, or you could model in 3D either doing some mouse work or in vitro using 3D collagen gels. So at the end of the day, you have, depending on the biomechanical forces the cancer cells sense, you could have either differentiated phenotype or malignant phenotype. And from a lot of work done by Valerie Weaver and her group and others, that depend, and also Ingber in the children's in Boston, that differentiated phenotype have this particular characteristics, whereas malignant phenotype have this particular characteristics. So changing gears a little bit, so coming back to the same question here, is that here's your tumor center, invasive front, and so if you take fluorescence imaging and say, what is the relationship between cancer cells and the collagen microenvironment? So what you're seeing here is breast cancer cells grown in, I believe it was like 5 mg per ml of collagen. And you can appreciate that if you have drug delivered all the way up here, trying to get some of the drugs to get into will be a big issue. At the same time, cancer cells do in fact escape and invade and go to other places. So how do these cells get through to these small holes? And you can see also that this is another breast cancer, H&E, or slide showing that you can see cancer cells are on the move. So you've got a group of cells going on. There's one leading cell here, and most of them march through the track or path created by the leading cell. And you can stain this is another group of cells. These are melanoma cells growing in 3D collagen. And you can appreciate that here's the 3D collagen matrix that they're trying to invade into. And as this cluster of cells invade, you can see it has left behind some clearing here. And you can see that in order to do that, the cells had to cleave some extracellular matrix. So which enzymes are important for cleaving type 1 collagen? And we spend a lot of time studying matrix metalloproteases because of the importance of type 1 collagen in pancreatic cancer and also in oral cancer. And you can see people have studied a whole bunch of them. You have got the usual early collagenases, 1, 2, 3, and you also have called gelatinases that can cleave denatured collagen. And of course, you've got most of these are secreted. A handful of them are membrane bound. And the one that has been shown to be key, or the couple that have been shown to be important for cleaving collagen, at least in the mouse models, is MMP 14, 15, and 16. And so we have spent over the years working mostly on MMP 14. And again, to show the importance of MMP 14 in collagen, so you can grow your cells in collagen. Over a period of time, after 3 days, they grow out like and you get a picture like that. If you knock down MMP1 or MMP2, so this is a collagenase and this is the gelatinase, it doesn't do much of anything. You have the same picture. If you knock down MMP14, you can completely block this invasive phenotype. Of course, you can also show that this result is because of knocking down MMP14 is by putting in this cell line mouse MMP14, do a rescue experiment. And when they do that, you can see that, in fact, you can show there's more invasion again. So a few years ago, when we were working when we started working in the area of pancreatic cancer, we looked at expression of MMP14 in human pancreatic tumors, and we found that areas of fibrosis, where there's a lot of collagen, there's also a lot of MMP14 taking place. So it makes sense. Cells escape and invade into the pancreatic tumors with the expression of a protease that cleaves type 1 collagen. And we could show that if you overexpress MMP14 in pancreatic cancer cells, you have this very invasive phenotype. A little bit of digression here is that, see, if you look at it here, when you grow cells in 3D collagen, most of the time you have ball-like structures forming. Whereas on plastic, you have all the same cells stretched out. There was a paper that came out recently showing that when you grow cells in 3D collagen, they are resistant to radiation treatment, in part because the chromatin structure is more tightly packed in 3D collagen compared to when the cells are grown on tissue culture plastic. So people have made mouse models, have knocked down MMP14, a whole bunch of MMPs in the mouse model, and I've asked questions, what kind of phenotype do these mice get? So if you knock down MMP2, MMP9, nothing happens to the mouse. The mouse looks essentially normal, unless you stress it, you give them either cause some sort of an injury or cause some sort of abnormal blood vessel formation, then you start seeing some sort of a phenotype. But if you knock out MMP14, first thing you want to appreciate is that the mice are much smaller and that they have a lot of difficulty with processing collagen. And they have the usual issues that if you're not able to process collagen, that's what you see. So we were interested in asking the question, we have shown that MMP14 is overexpressed in pancreatic tumors. We can't really use this MMP14 null mouse because this mice die within a span of 2 to 3 months, usually even less than that, because to keep this mouse going, they really had to work very hard to feed the mouse and all of that. So often they die within a span of a month or so. So of course, what we did, we overexpressed MMP14, TRMT, and then of course, through a whole breeding experiment, we generated mice that express MMP14 in the pancreas and crossed them with a KRAS mice to drive the whole process. So here's an oncogene to get the process going. And what we found was that if you overexpress MMP14, you have a lot more lesions forming. You can appreciate that compared to this. It's the same magnification. And you also you have a lot more lesions, you have larger lesions, and you have this particular something called intraductal papillary mucinous neoplasm. What surprised to us was that if you overexpress a protease that cleaves collagen, one will expect that the lesions will have very little collagen, because that's all, right? You're expressing a protease. That protease will cleave off the collagen, and the end result, there shouldn't be much of a fibrosis taking place. What we found that if you overexpress MMP14, you in fact have more fibrosis. This is not what you would expect if you had done stuff in vitro. In vitro, you express MMP14, the collagen gets chewed up, and whatever. So the question always comes is this because you have a lot of crosstalk taking place at the level of the tumor microenvironment? And so what we found is that MMP14 expression in epithelial cells, in cancer cells, affects proliferation of cells called stellate cells, which are resident fibroblast-like cells in the pancreas. And that because of increased fibroblast-like cells, you have more matrix deposition. So what you have here is again showing crosstalk at the level of pancreatic cancer. Is you have the stellate cells that usually reside and surround the acinar structures, and also some of the islet cells that make endocrine, make insulin. And once these cells get activated, they put down a whole bunch of matrix, they put down a lot of collagen, they put down proteases, and there's all this crosstalk that takes place. So cancer cells make growth factors affect the behavior of this cells, the stellate cells that affect behavior of cancer cells. So so when we stain the tumor samples where there was a lot of fibrosis, we could in fact show that areas of fibrosis had activation of this stellate cells or alpha smooth muscle actin positive cells. I didn't put in the slide showing that we could do in vitro culture showing that if you overexpress MMP14 in cancer cells, that affects the behavior of stellate cells through TGF-beta signaling. I think this is my last slide. I think my goal is just to have you appreciate some of the relationship between the cancer cells and the stroma. And you can see here that there's all this crosstalk taking place, and people have thought that hopefully some of this crosstalk will allow us to develop some therapeutic targets. Some of them make sense, some of them just don't make sense, but that's the way the world of oncology is. It means if you think about it, Avastin, if you can block angiogenesis with Avastin, single agent Avastin doesn't do anything. That's the reality of it. Single agent EGFR inhibitors give you about 2 weeks on average, 2 to 3 weeks. So even though we understand a lot of biology at a cellular level, but a lot of this thing doesn't seem to have panned out. But hopefully as we develop better mouse models, better appreciation of the microenvironment, we'll come to realize what some of our limitations are, and as we all try to at least think about treating our cancer patients. All right, I think that's my last slide. Any questions?
Are there prospects for targeting microenvironment to try to treat cancers? Is that
I
a
think-
practical kind of thing to try to do?
I think people have tried. People have tried targeting the microenvironment with Avastin. For example, the anti-VEGF antibody that targets the blood vessel, that was targeting the microenvironment. And once they targeted, they realized that it didn't quite work as well as they'd hoped. So for colon cancer, single agent Avastin, the response is essentially nil. If you combine with chemotherapy, you get a little bit more. So that's people have. So if you target, so that's the best example. Targeting MMPs, for example, the big thing is MMPs. People have been studying MMPs for the last 30 years. People can think about, okay, let us target matrix metalloproteinases because those are important for a lot of things. They're important for growth in collagen invasion. Studies have been negative because as we understand the biology, especially when we do mouse models, that not all MMPs are bad. We know that some MMPs are in fact anti-tumorigenic, and some MMPs, depending on the context, can be pro-invasive or anti-tumorigenic. So now, if you use a broad-spectrum MMP inhibitor, you just don't know what you're getting yourself into. And the other thing is that, the same issue often comes is that I have a target, I have a drug for that target. Means you could choose any of them. I'm going to give it to a patient and see whether it has any effect. What most people don't check is whether that drug was delivered to the target, whether it blocked that signaling pathway. None of that has been. A lot of that, when people do early clinical trials with EGFR, people have tried EGFR, and they just don't know whether they in fact block that signaling pathway. We just do it because it's a little bit maybe a technical issue or a difficult ethical issue is that for pancreatic cancer patients, you get your first biopsy, you know what the biology looks like. You treat them, and then when you say, okay, let me do my new drug, phase 1 trial or phase 2, most times we just don't go back and say, okay, after I've treated my patient, can I take a biopsy of that patient? It's easy to do. If you're doing leukemia, it's quite simple. I think leukemia is the simplest cancer model system if you think about it. Hey, the blood cancer, leukemia cells are floating in the blood. You take a little blood out, you can study it. And you can do a bone marrow biopsy. But if you have metastatic disease to the lung, nobody's going to say, okay, let me biopsy that lesion in the lung in hope that my phase 1 drug has done its job of blocking something. Most people, it's not. Again, a lot of ethical issues come into play. So going back to the answer, yes, they have been tried. The results have been what they are.
But I'm trying to relate it to my research. Are there any difference in pH between tumor cells, microenvironments, and normal cells?
Yeah, if you think about it, a lot of times as the tumor cells grow, right, they outgrow their blood supply. So when they outgrow blood supply, they become more and more acidic. So the pH drops in that microenvironment. So that affects. Yes, there's a big difference. Just as there's big difference in the oxygen level in the tumors, in the middle of the tumor. All of that plays to it, yeah.
And how many pH units of
that I don't know. I can email you, but I don't think it's going to be going from pH of 7 down to 1. I doubt that. Maybe in the range of 5 or 6, so maybe a few drops, yeah.